Okay, fine.
Yeah. Very good afternoon to one and all present here. Welcome you all for the webinar on decoding the concepts of embryology in India and newest developments in fertility medicine. We MedPiper Technologies is building a knowledge platform for medical professionals, connecting people, governments, organizations to enable better and faster healthcare outcomes. From building medical resume to medical webinars, we provide the platform and resource to help medical practitioners to tone their professional skills and update their medical education. Today, we have our expert speaker, Dr. PSR Murthy, Chief Embryologist and Scientific Director, Founder, Managing Director of Miracle Advanced Reproductive Center, Chennai, PhD in Biological Sciences from University of Nottingham, UK. He is the one of the key person who have initiated IVF lab in Apollo Hospital, Chennai in the year 1988. Pioneer in various fertility techniques from gratification techniques, in vitro maturation, etc. Over to you, Dr. PSR Murthy. Let's begin the session now.
Good afternoon, everyone. Thanks for the brief introduction. Today, I'm going to talk about decoding concepts of embryology in India and newest developments in fertility medicine. So, I would like to take you to the journey of how the IVF has evolved and to the present state where lots of work is being focused on artificial intelligence. Brief introduction about IVF. In vitro fertilization is a process by which an egg is fertilized by sperm outside the body. In vitro, in the glass. The term in vitro, from the Latin meaning in the glass, is used as early biological experiments involving cultivation of tissue outside the living organism were carried out in a glass container, such as beakers, test tubes, or petri dishes. This has evolved into a major treatment protocol for infertility. The colloquial term for babies conceived as a result of IVF is called test tube babies. IVF timeline. Back in 3rd century AD, record shows Jewish thinkers discussing possibilities of accidental or unintentional human insemination by artificial means. 13th century AD accounts of arrival using artificial insemination of horses. In 1777, Italian priests began experiments with artificial insemination of reptiles. In 1785, first attempts at human artificial insemination by John Hunter. A baby is born in the same year. In 1890, Robert Dickinson began experimenting with donor sperm, although his work was carried out in a secret because of condemnation of the church. In 1945, early reports of donor insemination published in British Medical Journal, which is a prestigious journal in UK. In 1955, 4 successful pregnancies using previously frozen sperm were documented. 1960, a big increase in knowledge of ovarian stimulation, how eggs mature, ovulation, fertilization, and the growth of the embryo in vitro, and the safer and better laparoscopic surgeries were introduced. History of IVF. The world's first test tube baby, Louis Brown, turns 43 this year. In 1978, first IVF birth in the world, resulting from Bob Edwards and Pat Strickland, pioneering birth in the UK. The birth of Louis Brown, the first test tube baby, was born as a result of IVF. History of IVF in India. Dr. Subhash was a physician from Kolkata, India, who created world's second India's first child using in vitro fertilization. Durga, who was born 67, his first IVF baby in the UK. Unfortunately, he was harassed by the state government and not allowed to share his achievements with the international scientific committees. So he got dejected and committed suicide on 19 June 1981. A critically acclaimed film, Take Doctor chemo was made on his life in 1990. Indications of IVF. IVF is most clearly indicated when infertility results from one or more causes, having no other effective treatment. Tubal defects. In women with blocked fallopian tube, IVF has largely replaced surgery as a treatment of choice. Here, I would like to bring to your notice that the world's first IVF pregnancy resulted as ectopic pregnancy, and this was mentioned in The Lancet in the year 1976. Then packaged up the thought the best way to get pregnancy would be bilateral tubal block patients. The patients with a bilateral tubal block will be the ideal candidates for IVF procedure. Then he started lining up some patients. So one of the lucky lady was Louis Brown's mother, who had bilateral tubal block. It was successfully treated and delivered a baby. Endometriosis. The patients with endometriosis often have tubal involvement and ovarian cyst. Ovulatory dysfunction. In patients with polycystic ovarian disease, PCOS, and irregular menstruation. Age-related infertility. In normal reproductive life, the woman's ovarian function is diminished with age. In many cases, this reduced function can be overcome through use of IVF. Male factor infertility, azoospermia, oligospermia, actinospermia, or antisperm antibodies present in the seminal plasma can be successfully treated using IVF. Implantation genetic testing. Genetic testing on pre-implantation embryos may be indicated for patients who are at the risk of genetic disorders such as cystic fibrosis or thalassemia. Indications of IVF. These are the various indications. The tubal factor 9%, ovulatory dysfunction 7%, diminished ovarian reserve 10%, endometriosis 5%, uterine factor being 1%, male factor about 18%, unexplained infertility 12%, multiple factor female only is around 12%, and other causes can be 8%. Steps involved in IVF. Initial evaluation of the couple, suppression of natural hormone cycle, ovarian stimulation, collection of oocytes, collection of sperm, in vitro fertilization of oocytes, embryo transfer. When the couple walks in, so we evaluate by doing blood tests like hormonal assays, basal hormone assays. Yes, ma'am. Hello. Hello, can you hear me?
Yes, better, sir.
Hello.
Yes, sir. Better.
Yeah. Hello.
Yes, sir. Your voice is audible. Better.
Sorry about that. My AirPods were giving some trouble, so I had to get rid of it. Sorry about that.
No problem.
Well,
No
when
problem.
the couple walks into the clinic, and then we evaluate initially by doing some blood tests like hormonal assays and the protein screening tests in the blood. And for men, we do the semen analysis, and hysterosalpingogram is done to make sure whether the fallopian tubes are open or closed, or it may be blocked. Transvaginal ultrasound is done to evaluate the ovarian status or to rule out the cyst. Ovarian stimulation. Ovarian stimulation is used to produce multiple mature follicles rather than a single dominant follicle, normally developed every month. Regular monitoring by ultrasound scan should be done. Inducing ovaries produce follicles to collect around 5 to 10 oocytes. Oocytes collected, some of them will not fertilize or develop normally after fertilization. Good quality of multiple embryos are essential for the good outcome of the results. The medications for ovarian stimulation, human menopausal gonadotropin, follicle stimulating hormone, luteinizing hormone used in conjunction with FSH, human gonadotropin, and clomiphene nitrates are used. Medication to prevent premature ovulation, gonadotropin releasing hormone agonist, GnRH antagonist. Generally, 8 to 14 days of stimulation is required. During the course of stimulation, periodically we do a scan to find out follicle development. So this is how the scan will reveal with the multiple follicles. Possible side effects of ovarian stimulants are discomfort, bruising or swelling at injection site, rashes, allergic reaction, headache, mood swings. Mood swings are very, very important point. This has to be discussed with the couple during the course of counseling. And when we start the follicle stimulation, the husband should be well informed about the mood swings so that he gives them full support to the wife from the course of stimulation to the entire process of IVF and ET. Abdominal discomfort and bloating, chances of multiple pregnancy, ovarian hyperstimulation syndrome. Ovarian hyperstimulation can result in enlargement of ovary with leakage of fluid in abdomen and rarely into lungs. Most cases are mild, but a small portion of are severe and fatal. Treatment of OHSS depends on the severity of hyperstimulation. Mild OHSS can be treated conservatively. In moderate to severe OHSS, develops the embryo transfer procedure should be postponed since establishment of pregnancy can lengthen the recovery time or might contribute to more severe condition. Collection of oocytes. The oocyte maturation is performed generally by injection of human gonadotropin, commonly known as trigger shot. Oocytes retrieval is performed at the time usually between 34 to 36 hours after HCG. Egg retrieval is usually accompanied by aspiration of follicle fluid with the guidance of transvaginal ultrasound. It is done under short general anesthesia and is about 20 to 30 minutes procedure. In some circumstances, one or both ovaries may not be accessible by transvaginal ultrasound. Laparoscopic oocyte retrieval may then be approached. Follicular aspiration is follicle fluid is aspirated from the follicles through the fine needle connected to the suction device in the test tube. This is a schematic representation where the transvaginal probe and the needle is passed through. The other end of the needle is connected to the fine tubing. This goes to the tube, and the other end enters the suction apparatus. Usually, 5 to 10 follicles are aspirated. Oocytes are collected and stripped from surrounding cells using enzymatic treatment and mechanical freezing. After the enzymatic treatment, oocytes are examined under the stereozoom microscope for maturity and quality. Mature eggs are placed in IVF culture media and transferred to an incubator until further processing. So usually after the collection, egg is seen like this. It is surrounded by coronal cells and cumulus euphorus mass. You can hardly see the inner of the egg. So we do not know whether it is a matured one or not. So after enzymatic treatment and removing these cells mechanically, then the egg will appear like this. So it has the clear zona pellucida, the perivital space, cytoplasm, and the extrusion of first pore body, indicating this is a mature egg. Preparation of sperm. Shortly before or after the oocyte collection, the male partner will be asked to give a semen sample. Usually, with sexual abstinence of 3 to 4 days. Semen then collected 60 to 90 minutes prior or post oocyte retrieval. Liquefied semen is centrifuged, suspended in culture media, and incubated for about 30 to 60 minutes at 37 degrees. Most active sperm are located on the surface of the media, that is the supernatant of the fluid, which is aspirated, and that is used for inseminating the eggs. Sperm may be obtained from the testicle, epididymis, or vas deferens from the men whose semen is void of sperm, either due to an obstruction or lack of protection. The surgical sperm retrieval. Percutaneous epididymal sperm aspiration. This is done by a very fine needle. The butterfly needle is used to aspirate, or it can be done microsurgical epididymal sperm aspiration, like scrotal exploration, and under the microscopic condition, we can aspirate sperm. In vitro fertilization of oocytes. Fertilization is started by adding 10 to 50,000 motile sperm to the culture media in which the eggs are placed. Intracytoplasmic sperm injection, ICSI, is indicated in case of impaired sperm parameters and surgical source. In vitro fertilization by ICSI. During the process of ICSI, an embryologist selects the sperm into a fine microscopic needle and injects it directly into the oocyte using high power inverted microscope. So it's like this. Okay, they're holding the egg, and there's the injecting pipette in which the sperm is picked up, and it is injected and gently deposited inside the egg and slowly come out. Fertilization check is performed the next day, approximately 16 to 7 hours after the sperm injection or insemination of the oocytes. Usually 65 to 75% of mature oocytes will fertilize after insemination. They are cultured in special incubators to support division and development. If the couple has a history of certain genetic disease and the gene that is causing the problem is identified by pre-implantation genetic diagnosis. Development of embryos. So after about 16-17 hours later, or the post-insemination, when we look for fertilization, we will be able to demonstrate 2 pronuclei in the egg, indicating one has come from the sperm, another one has come from the egg. Usually, nuclei lying very close to the polar body is from the egg. On day 2, we look for 4-cell stage, and day 3 it becomes 8-cell, and for day 5 it will lead to 200 to 300 cells, and this stage is called blastocyst stage. Embryo transfer may be performed on day 2 to day 5 post-fertilization, depending on the cell stage. If you want to do it when it is at 4-cell stage, it will be on day 2, and day 3 referring to 8-cell stage embryo replacements, and day 5 will be the blastocyst stage. One or more embryos are suspended in a drop of culture media and are drawn into embryo transfer catheter, a long, thin, sterile tube with a syringe on one end. Physician gently guides the tip of the transfer catheter to the cervix and places the culture media containing the embryos into the uterine cavity. So this is how it is, and there's a transfer catheter attached with the syringe, and the embryologist picks up the embryos from the culture droplet and gives it to the clinician. Clinician gently places under the ultrasound guidance. This is how the catheter appears under the ultrasound guidance. So it goes near to the fundal region, and the embryos are gently deposited. What are the percentage of success? Age of the couple plays a very important role in success of IVF program. Female aged between 20 to 30 years are likely to get about 20 to 60% pregnancy. Between the age 31 to 34, it's going to be about 20 to 40%, and the age between 35 to 40 are likely to get about 15 to 30%, and the age between 40 to 45 are likely to get about 2 to 10% pregnancy rates. These are the latest developments in the treatment, potential accomplishment in fertility treatment. IBM, in vitro maturation. This process involves the collection of immature oocytes and mature them in specialized culture conditions to attain maturation. So we can use these matured eggs for IVF. For polycystic ovary patients, when we go with a conventional protocol of stimulation, they are moved for hyperstimulation. Such group of patients can be opted IBM, whereby we go with a very few days stimulation, about 3 or 4 days stimulation, and when the follicles are about 8 to 12 mm in size, we give a triggering shot and go for the egg harvest. So thereby we can prevent hyperstimulation. Cytoplasmic transfer. Defined procedure when a small portion of healthy cytoplasm is injected into poor quality oocyte to improve the quality, and it is of two types, autologous and heterologous. Risks involve transferring mitochondrial maternal disorders to the offspring should be thoroughly screened. Fertility preservation. It's a wonderful procedure for the women who are career-oriented and oncology-related issues to freeze the oocyte or semen for further use. With the advancement of ovarian cortex freezing and testicular tissue freezing being standardized and getting lots of attention in this area nowadays. During this COVID pandemic, so what are the guidelines that has to be followed? So we follow according to the ICMR guidelines, like starting the treatment after negative RT-PCR and storing the gametes in the separate cryo storage for infected samples, and closed freezing system is recommended. There are a few papers such as undetectable viral RNA in oocytes from SARS-CoV-2 positive women, and one more paper, undetectable SARS-CoV-2 RNA in oocytes. So they do not find any virus coming from the eggs. And as you know, it's a viral infection. At least from this paper, we understand that oogenesis is not affected. But coming to men, always the viral infection interferes with the spermatogenesis. I think a caution should be taken when he is recently infected. So give him some time, let him recover completely, and then we can get good number of sperms. So definitely the virus is going to interfere with spermatogenesis. So thereby post-infected men should be given enough time, at least 4 to 5 months recovery, and then you can opt them for IVF procedures. Future embryology in IVF. Non-invasive detection of blastocysts 5D using artificial intelligence with deep learning methods. Artificial intelligence in human in vitro fertilization and embryology. Deep learning enables robust assessment and selection of human blastocysts after in vitro fertilization. It's a very good article. Coming to 40 years of IVF, this is a very good paper, and it has been given by many scientists and authors, lots of experience in this area. They have the views and the experiences widely shared, and I would definitely recommend everyone to read this paper, which is very interesting. The full in vitro fertilization laboratory mechanization towards robotic assisted reproduction.
is going to be the future. Thank you for your attention. I thank organizing committee, MedPiper Technologies, for giving me opportunity to talk on the subject today.
Thank you, Doctor. We have one question from Damodar Kini. He have asked, you mentioned about viral RNA is not found in oocytes. What about viral exposure OS embryos in very early pregnancy, like rubella virus? The question is there in Q&A.
Yeah.
If I'm not spelled the word correctly, you can check.
So you mentioned about the viral DNA. Just say it. Okay, I'll just type it. Yes.
Sir, you can actually answer the question, I mean, so that others also can listen to it.
Okay. Good afternoon, Dr. Kinney. I don't know whether Dr. Kinney hears me. Anyway, it's a very good question, and lots of work is being done, and we still do not know. Okay. Hello.
Yes, doctor. Doctor, you mentioned about the robotics, technological advancements in IVF. Can you just brief little more, like what we are, having right now? What are kind of treatments that you have been following right now? Maybe if you can share
Okay.
us.
Yeah. Basically, now lots of work is being done in artificial intelligence. What they're focusing is, they are studying very closely the quality of the embryos that can be generated from the IVF lab, so that they can pick and choose the embryo which has got high potential for getting implantation and pregnancy. So this is the area where lots of focus is being done, because when we go for embryo transfers, we look at the embryo or we select the embryo based on morphology aspects, and we do not know the genetic material components in the embryo. And now lots of kinetics has been involved in the development of the embryos. So based on the time frame, they see or they monitor the embryo very closely. Thereby, they are able to come to a point where now they are able to tell the probability of implantation rate of the particular embryo. So this is one of the biggest breakthroughs that has been happening right now.
Thank you, doctor. And I have one more question to ask. I think it will be a little bit different. Maybe it's not a medical topic, but is maybe fertility treatment. Do you think that there has been inequality you felt while treating the patients? Like as you rightly said, we need to convince and we need to give sessions to even the partner as well. So do you think that addressing inequality, infertility treatment, can you share your thoughts about it?
So when a couple comes, we do lots of counseling. Sometimes, some personal attention has to be given to the individual partners as well. And they are basically, longing for so many years for the want of child. And we have to motivate them and talk to them about this various aspects. As I told you, the mood swings are the vital thing that happens in the couples that I've seen. Okay, so we talk to them and take it from there. Otherwise, I don't see any difference between the approach.
Thank you, doctor. We have two more questions in the Q&A. Doctor, do you want me to read or would you like to see? And
Yeah, let me see that.
yeah.
In me, okay. I see one question from Koran Rana. If male sperm do for the age 30 and female 50, there's a huge age difference. What are the probability of embryo production? So male age is 30 and the female is 50. So usually in this, as long as she is getting ovulation, we can still try. But as I mentioned earlier, over the age of 40, the fertility rate declines very fast. And even when we try getting pregnant, the pregnancy rate is around 2 to 5%, okay, by the age of 45. And over 50 or around 50, if you don't get good quality egg, definitely it's not going to result in good embryo. And thereby, we cannot expect good outcome from that embryo that has been transferred. And this group of patients, usually over 45, they are more prone for chromosomal abnormalities in the egg and haploidity. So I would suggest we have to discuss with them and take them for the donor egg program. That will be the vital choice for this couple. But for the age of 30, I don't think that's going to interfere for them. Good afternoon, Dr. Sita Sahu. So you have asked about PGT in recurrent implantation failure. The pre-implantation genetic screening is one of the main indications for recurrent implantation failures. So we have to opt them. If a couple comes to you and especially the lady has got at least a couple of times recurrent miscarriages, the third time when we go with the IVF treatment, and you have to take them through PGT so that we can pick and choose the embryos which are free from this, abnormal chromosomes or aneuploidity. Pick up euploid embryos and transfer with a better outcome of the results.
Doctor, Mr. Damodar Kini have asked one more question related to gynecology as well.
Okay. So do you think IVF will need to be carried out in certain well-likely labs? Well, Dr. Kini, I think in near future it's going to be like that, because all hi-fi labs will be brought in where you use all these high technologies. Maybe 10 years from now, the things will drastically change. Any other questions?
Doctor, do you think that the demand of IVF treatment have increased in India? And what is your thought about it?
Definitely, it has increased, and once in 10 years, when we look at the statistics, it is always, on incremental only. It is not coming down. And especially after all this, pandemic, and I'm sure this has definitely affected many couples, for men especially. We have seen lots of, reduction in the sperm concentration and the motility it has affected. As I told you, we'll have to wait and see. And when you asked about this is now becoming more and more. Many clinics are coming and the patients are there, lots of patients. And I would say, although this has evolved some 40 years ago, Now, recently, over the last 10 years, it has taken a sea change in this technologies. And now it is becoming like a $1 trillion industry. Hello?
Doctor. And Sitamani Sahu have asked one more question. What is the success rate in PGT? The question is there in the Q&A.
Yeah.
Yeah.
Sitamani Sahu. Dr. Sahu has asked, sorry, can you read the question?
Yes. The question is, what is the success rate in PGT?
Okay, PGD. So after screening the embryo and picking up the right embryo, that is euploid, and when we do the transfer, we are definitely getting about 10 to 20% increment. And when I say the increment, the globally the pregnancy rate is around 40 to 80%. But when you look at the take-home baby rate is something like 20 to 40%. So we definitely have seen the incremental in take-home baby rates, the embryos that has been duly tested for PGT. So I think even in future, many clinics will of doing this technique so that they can pick up the right embryo and transfer so that they get the good results and the take-home baby rate is increased.
Thank you, doctor. We have another two more questions there. Is there 100% chance through IVF procedure, embryo production, if other factors are nullified like age, mismatch, and stress?
Okay. Rana, I would like to tell you that basically we have to understand what is the success rate in nature. When you look at the nature pregnancy rate is around 30% only, to be very precise, 29%. So from this, we understand that nature itself is giving us 70% negative results. So when we go for this IVF procedures, how can we be sure for giving you 100% pregnancies? So we cannot. So every procedure has got its own limitation. Basically, if an egg is coming from the young age group around say 25 to 30, they tend to have a good quality egg and the fertilization takes place resulting in good quality embryo. So chances of getting pregnancy is definitely higher in that group when compared to the group of after 35 years. And when you ask about getting fertilization from the lab point of view, using the egg and the ICSI method, we can definitely get maximum fertilization possible because ICSI is a powerful tool. We are picking up the right sperm and injecting it directly into the egg to get fertilization. This can fail if it is a conventional IVF where multiple sperms try to enter the zona pellucida. But here at least we have come to the level where we can maximum get fertilization by using a powerful tool called ICSI. Okay, so but we cannot assure you pregnancies or good quality embryos. It's a multi-factor. It may be, if it is a poor genetic material coming from the sperm, definitely it is going to result in poor quality embryo. And so is if there is some genetic problem in the egg, that is also going to contribute the same. So we cannot assure you at the end of the day to make sure the embryo is a good quality or whether it is genetically normal, that can be tested for PGS screening. So thereby we will be able to pick up whether it's a normal embryo and we pick up the embryo and go for embryo transfer. Any other question, please?
Yeah, thank you, doctor. We have one more question from Dr. Sahu. Now, lots of seminar is coming up in LIT, failed IVF. What is your opinion? The question is there in Q&A.
Oh. Dr. Sahu. IVF. Dr. Sahu, I'm sorry, I'm not able to catch up with LIT. Could you please tell me what is this LIT referring to?
Okay, before that, can I ask one more question, doctor?
Yeah, please, go ahead.
You spoke about IVF cycles, no? So,
Yeah.
is there any break or the days after this much days you have to come for another cycle or 4 weeks, 5 weeks, 8 weeks, something like that? Can you just brief the IVF cycles in detail?
So nowadays, what's happening is, it is we have got excellent freezing system, and with this freezing system, which is the latest one around, about 15, 20 years, this system called vitrification. With this, we are able to freeze eggs successfully, and so is the embryos. The outcome of this freezing technology and the thawing when we thaw or the warm the embryos, nearly 90 to 100% we get the recovery when compared to the conventional freezing system, which is now obsolete. And nowadays, what we are doing is, freeze all cycles. So usually the treatment begins on day 2 of the cycle. It goes for about 2 weeks, the stimulation protocol, and then we go for the egg collection. And there will be something like a harvesting cycle. We collect the eggs and we make embryos, and all the embryos are subjected for extended culture. That means we grow the embryos up to 5 to 6 days in the lab, select the best embryo, which is going to be blastocyst stage, and freeze them and use it later on. So when I say later on, the earliest time you try to put back to the lady would be at least 1.5 months later. So nowadays it is like, we are getting, so we definitely space them. It takes at least 1.5 months to 2 months. Supposing having undergone embryo transfer, and if she has not conceived, before we opt for one more cycle or embryo replacement, we always give a spacing of at least 1 month.
Okay, doctor. Thank you. I think Dr. Sahu have replied. It's leukocyte immunization.
LIT, leukocyte. Okay.
Yeah, the question is now lots of seminars is coming up in LIT failed IVF. What is your opinion?
Okay. Yes, single embryo or yes, Dr. Sahu. Nowadays, we are doing only SET or single embryo transfer or dual, that is double embryo transfer. And coming to leukocyte immunization program, say now I think we are not doing leukocyte immunization, but now to improve the implantation rate, recently we are doing plasma-rich, platelet-rich plasma. So that is being focused. Okay, and instead of leukocyte immunization.
Thank you, doctor. We have one question from Lizzie. Sir, I want to know 1 month very good pregnancy, other month very low. What would be the reason?
Is this question from the lab, I guess, I think the embryologist or someone asking, okay. This could be, various factors, especially we have to see the culture conditions and make sure that enough humidity is being maintained. and we have to check the pH levels of the culture media, okay, and the temperature. All this has to be monitored very closely. And I would like to ask even if there is a drop in the fertilization. See, normally when we establish an IVF lab, every lab has got its standards. So even I mentioned, when you look for the fertilization, at least your lab should have 65 to 75% fertilization. And so is when you look at the cleavage, that is the cell division, which is going to progress into an embryo and to the final stage of blastocyst. Again, there may be a drop of 10 to 20%, which is acceptable after the fertilization score. But when you see in one particular batch, it is about, you've got about 70% fertilization and about 60% formation of embryo, and the outcome you're seeing. And very next month, if you find the fertilization is dropped by 50%, or you're not able to get good quality embryos, this itself indicates that something wrong with the lab, which you have to see. Basically, you have to check the temperature, pH, and the humidity system in your lab.
Thank you, doctor. We have one more question. I'm not sure who have asked, but the question is: do you think there is a role of stem cells to improve implantation? The question is in Q&A. Do you think there is a role for stem cells to improve implantation?
Okay. See, here, right now, we are not focused on the stem cell and the implantation. We mimic that, by taking the platelet-rich plasma. So we take the lady's blood, we harvest the platelets, and then inject them directly into the uterine cavity. And this has shown some degree of improvement in implantation and the outcome of pregnancy. Only that is being done, and especially when we notice the endometrial thickness is not optimum, then we offer this, and then we have got few pregnancies and deliveries too.
Thank you, doctor. Dr. Sahu have replied. In UK, no one recommend LIT, but it goes as viral in India. And who regulates all these new techniques as we follow HEFA regulation?
Well, in UK we have got HEFA, but in India we still have to stick to the ICMR guidelines. It is not okay. So I think as of now, with the experienced doctors, they have their own limitation and they try these methods. And I thoroughly, agree with Dr. Seethamani Sahu says. Unfortunately, in India, we still have to follow only ICMR rules.
Thank you, doctor. Doctor, next question is, I just want to know, you have mentioned as the age goes, the female fertility declines, right? So maybe in case any options available for women if they are planning to delay in having children.
Yeah, definitely. It's a very good question. I would say fertility preservation is the answer to that. Okay. For example, a lady who has married, 28 years and she's thinking of making babies when she's maybe around 33 or 34. She can opt the eggs to be frozen, when she's 28 years. Let her come for one round of egg collection. Maybe if we collect about 10 eggs, freeze them. Then after later on, when she tries to try to make a baby on her own, if it fails, at least this will be like a backup. When we look at the quality of the egg that has been frozen when she's 28, it's not going to be the same when she's 34 years, isn't it so? So this will be the ideal thing, to freeze the eggs and use it later on whenever she needs it. And same thing goes even for the a lady who has got cancer during the reproductive age can opt this before the oncologist starts treating her. So we can harvest the eggs and keep it. after successful completion of the oncology treatment, she can come back and they make babies from the frozen eggs.
Okay, thank you, doctor. We have spoken about female infertility, PCOS conditions and everything. And maybe can you share a few things about, male infertility or about sperm freezing for a better understanding?
Semen analysis and the semen freezing techniques have been there for the last 40, 50 years. But now the recently, it has come to the place where even a single sperm can be frozen successfully and used. So we have come to that level. So thereby for men, even if they have about 100 sperms, let him not get dejected. So he has to come, take a treatment, and ICSI is the best answer for that. Let him not start taking medication after medication, thinking, okay, this 100 will become 1 million, 1 million will become 20 million. It is not so. The age is also very important for them. So let them not waste the time. When the semen report shows few sperms are found, then itself he can come for the treatment. Earlier the better. So this is what they have to bear in mind. Although then he can keep producing sperm. It's like day to day, and even when he's 80 years, we can still get few sperms. But again, the quality of the sperm that matters. So thereby, I would strongly say, during the young age itself, when they find few sperms, let them not wait to make it as millions and millions. Let them go to the center, get the best line of treatment, and then later on they can think of starting treatment for them and trying to make baby. So I would definitely insist the time is very important for them. So is a lady of 38 years, we have to focus on her and make them understand to take the treatment as early as possible, because the quality of the egg deteriorates. If she says, okay, let me come back to your doctor after 1 year later, so we have to tell them, say, what the chances you get today is not going to be the same after a year later. So this we have to make them understand.
Thank you, doctor. Next question is, if endometrium is not optimal, do you recommend for endometrial receptivity test? Is it available in India? The question is in Q&A.
Yes.
Yes.
Endometrium is not optimal, do you recommend? Okay. See, we have got endometrial receptivity tests. Okay. And the outcome is not that great, when you compare to the study that has been done. And we don't do this as a routine. And for endometrial thickness, I mentioned earlier that plasma platelet can be used to increase the thickness of the lining. And that has worked quite well with us. And we have got few babies born by that. So we opt for platelet-rich plasma infusion intrauterine. And after about 2 or 3 days later, we go for embryo replacement, which is giving us good results.
Thank you, doctor. We have one more question. With the use of IVM, do you think OHSS will be 100% eliminated?
Well, by using IVM, yes. I would like to just share my experience. Myself and the clinician, Dr. Kinney here only, he's there. So Dr. Damodar Kinney, when we were working together in abroad, so we have been doing IBM. We just started then. And then, in fact, our first baby born by IBM, is 21 years, and she is now doing artificial intelligence in UK. She's doing masters in artificial intelligence in UK. So this IBM is not something new for us. And we have definitely prevented lots of OHSs. As I told you, the conventional protocol for polycystic ovaries, when we take them, they land up with multiple follicles, about 30, 40. And in our program, IBM, we have got a fixed protocol. See, they tend to have longer duration of cycles, okay, about 30 or 40 to 60 day cycles like that. So and then when they come, when we start them for IBM, on day 2, we do a scan and we start the medication on day 3 or day 4. Only 3 days we give them the medicine. That is, the ovarian stimulation is done only for 3 days, like day 3, day 4, day 5. Day 6, we don't give them anything at all. And day 7, we give a triggering dose. And day 9 will be the egg collection, whereby the follicles are going to be something like 10 to 12 or maximum like 14. And we harvest the eggs from such follicles. And then, as I told you, we are going prematurely. So we are not focused in transferring the embryo in that particular cycle, because the endometrium won't be adequate, thick enough for the embryo replacement. So it's all going to be freeze or cycles. So we collect the eggs, we mature them in the lab. It takes about 30 hours. And then we fertilize them using ICSI. And then we generate embryos, use it later on. We make the blastocyst, freeze them, and use it later on, which has given us very good results. So by this technique, we have, of course, 100% eliminated hyperstimulation. And I can tell you, the last patient I have seen when I was working with Dr. Keeney was admitted in 1996. And then after that, I have not seen anybody getting admitted for OHSs, at least, even when we started in Chennai, from day 1 till now, we have not admitted anybody under the name of OHSs. So we manage them very well. As I told you, during the course of treatment, even after 5 days, if we think that, okay, she is going to go for hyperstimulation, we can stop the medication and switch them to IVM, which is going to prevent this hyperstimulation. So it's a very good technique. But definitely, this has to be, the embryologist has to be trained very well, because identifying eggs is a tricky situation. And another thing, even the clinicians has to be taught very well for their collection, because the follicles are not that big enough. It's going to be tiny, tiny ones. Again, it's a highly skilled procedure. The clinician aspirates and we get the fluid and we look for the possible immature egg in that fluid. Once when we get it, and we take it through and through to develop them to a beautiful embryo in the lab. Yes, definitely we can prevent hyperstimulation when we switch that group of patients for IVF.
Thank you, doctor. We have another 2 more questions. One is, with advent of stem cells technology, do you think we can generate eggs and sperm in the lab? So donor egg and donor sperm will be all pass-through?
Well, it's a good question. Right now, in Japanese people, they are doing lots of work. And, from the stem cells, they're trying to make sperm and eggs. But still, it is experimental. Yes, there are lots of work focused on this area, trying to generate eggs and the sperm in the lab. Yes.
Thank you, doctor.
And I see one more question, from Lissy, I think from Bahrain. Our lab fertilization is 85 to 90% division. Again, very good embryo, some low pregnancies. Why, sir? I think if the embryos, everything is being generated very well from the lab, I think they have to focus on the clinical aspects. Sometimes, what happens, even the clinical support may be inadequate enough, or sometimes batch to batch variation in the medication that is always seen more in India than the overseas, I would say. I don't know why. So, batch to batch variation in the medication can also lead to low pregnancies. I think you'll have to focus on that disease. And Dr. Seethamani Sahu has asked the success rate in IBM and IVF. Once when you generate the good quality embryo from IBM source, and when you transfer one or two blastocysts, I think the outcome is going to be the one and the same. So we are not going to compromise the outcome by switching them over to IBM.
Thank you, doctor. I think Mr. Rana have asked, kindly send details of journal links. Maybe if you can share with me, I can share with him. Maybe.
Yeah, sure. So we'll do that. Yes,
Sure.
Rana. I'll definitely keep in touch with you and we'll send it to you. Okay.
I think, doctor, we have answered all the questions, no?
So can we wind up or?
Yeah, someone have asked one question in the chat box.
Could you please read that for me?
Yeah. In the beginning stage up to 4 to 8 cell stage, it is only the genetic information of oocyte which is responsible for cell division. After the genome activation fails, 1 minute,
Yes.
there occurs the embryo.
Yeah, I got that question.
Yeah.
Yes. In the beginning of the stage. Well, for this, the best answer would be if we can take it to blastocyst stage and do PGS for this group of embryos. Okay, thereby we can pick up the right embryo and transfer.
Yes, doctor. I think we have taken all the questions and yes. Mr. Sahu mentioned, thank you, Murthy, very much, and nice presentation.
Thank you, Dr. Sahu.
Yeah, and someone was asking, is the webinar recorded? Yes, the webinar is recorded. We'll be, editing the webinar thing, and we'll be updating in our YouTube channel, and we'll share accordingly. Doctor, can we wind up for the day?
Yeah, thank you very much for giving this opportunity.
Yes, doctor. Thank you so much for spending your Saturday evening with us in sharing the latest advancements and treatments available in the fertility medicine and IVF. There are so many questions still there in the mind regarding IVF. Maybe the various stages of IVF. When a person can go for IVF treatment. Is IVF the last option for having a baby? A lot of questions are there, but still again.
Yeah, we'll answer all those. Okay.
Yes.
Anyway, thank you very much once again.
Yes, doctor. Thank you so much. Thank you, doctor. Thank you so much for sharing all these updates with us, and we shall be working on, the next topic related to IVF and infertility treatments as well, so that we can meet up other set of, I think there are more questions from embryologists and lab-based questions. I think we can focus another session on that, so that will be much useful for the attendees as well. Once again, thank you so much, and on behalf of MedPiper Technologies and Jonamed, and thank you attendees for staying back so long and listening to us and asking all those wonderful questions where sir patiently answered everything. Thank you. Yeah.
Thank you. Thank you, Babu.